Welcome everyone to the Society of Thoracic Surgeons General Thoracic Surgery Database monthly webinar. Today is Wednesday, September the 13th. So thank you everyone for joining. On the call with me today, we've got from the STSI, we've got myself and Carol Crone. We also have from our core group and consultant, we have Katie Lothrop and Ruth Riley joining today. And then also we have a brief special guest joining us today. We have Dr. Chris Cedar joining us. From those of you that are not aware, Dr. Cedar is our GTSD task force chair. So he will be joining us momentarily to give a brief update regarding the temporary field. So in the meantime, I'm going to go ahead and kick off with our STS updates. Then I'll turn things over to Dr. Cedar, and then we'll finish up with Ruth with our education update for the month. And then, as usual, we'll finish off today's webinar with your Q&A. So if you have any questions, please feel free to put those into the Q&A and not the chat. Let me actually go ahead and turn that chat off so we don't get confused. So again, just please submit your questions via the Q&A. Also, we do have that raise hand function enabled. So if you would like to ask your question directly, please feel free to just raise your hand and ensure that your microphone is enabled on your end, and I'll be sure to unmute you. All right. Before we get started, let's go ahead and start with our STS updates. I'm not sure if Dr. Cedar is available just yet, but let's go ahead and start with those. The September training manual will be posted by the end of this week. So look out for that by Friday or first thing Monday at the absolute latest, but that September training manual will be posted. Our fall 23 harvest has closed. It did close on Friday, September the 8th. So thank you to everyone who got those files in, greatly appreciated. That fall 23 harvest will include surgery dates of July 1, 2020 up through June 30th of 2023. And then our September 24 harvest is currently underway. So if you have if you would like to, you are free to go ahead and submit surgery dates for January 1, 2021 up through 12/31 of 2023 for the spring 24 harvest. We don't have that harvest close date set just yet, but it will be coming soon. And as always, it'll follow around the same time as our typical spring harvest. So around, I think it's usually in March. So we'll have that official harvest close date coming soon. Our next public reporting update is scheduled for winter of 2023, so later on this year. And that public reporting update will reflect the fall 23 harvest results. More information on when that update takes place will be coming from the STS directly, so look for communication regarding the next public reporting update scheduled for later this year in winter of 2023. Next, we're just going to, I'm going to turn things over to Dr. Cedar here shortly. I don't know, Dr. Cedar, are you available? I don't know if he's back yet. Going. I don't think so. But in the meantime, so just before Dr. Cedar hops on, again, he's going to briefly discuss the activation of the two STS temporary fields. So we do plan to activate these two fields on October the 1st. We are, again, as we had talked about previously, we'll be activating sequence 4580, the temp yes/no field. And we'll be activating sequence 4620, the temp text field. We will send a formal communication to all of our GTSD participants and vendors, notifying them of the official activation date for these temporary fields. And please, if you are currently using these two fields, please stop. I will be reaching out to those sites individually. If you are using these fields, again, if you are using them, please stop. If you need to, go ahead and reach out. If you are using them, reach out to your vendors, make arrangements, but please discontinue use of these fields if you are currently doing so. Let's see. I was just taking a look at the two questions. Dr. Cedar, are you available? Sorry, he's in and out. He's in and out of clinic today. So I am going to.
I can talk about clinical staging if you want, Leanne. Do you want to skip to my slides?
Yep, let's go ahead and do that. Actually, let me go over the AQO stuff rather quickly. Sorry. Just a reminder, AQO is coming very soon. It'll be in 2 weeks. I think we are about 2 weeks out. Registration is now open, or registration is open if you have not registered already. I think right now we're at a little over 400 people, I think, are currently registered for AQO this year. So we are looking forward to the conference in a couple of weeks. In 2024, we will be returning to back to an in-person conference. So we will have more information about AQO 2024 in the coming weeks. So stay tuned for information on AQO 2024 and back in person. Again, just a reminder, the General Thoracic Day is scheduled for Wednesday, September the 27th. There is an agenda out on the STS website if you would like to go take a look. All that information is posted out on the AQO page. If you go to the STS calendar of events and click on the AQO data managers meeting, all of the information is there. I've had several people reach out wanting to know if when they'll receive their login information. Just before AQO begins, I suspect sometime next week, before the conference starts, participants will registrants will get an email from us, from STS, sort of a know before you go communication that'll include your login information, a link to the virtual platform. So we are working, Emily and her team are working on getting all the presentations uploaded to the virtual platform. So again, that know before you go email, look for that in the probably sometime next week. And again, it will have all of your logon information and all the know before you go info for before AQO starts. Quick check with Dr. Cedar, see if he's available yet. Not yet.
And
okay.
You might want to, before we go to Ruth, you might want to run through the agenda on AQO. I think it's really exciting, and
Okay, perfect.
if folks don't know how to quite navigate the website yet, this might be a great way to show them. I know the adult group liked seeing the agenda.
Perfect. So yeah, so for those of you that aren't familiar with how to get out there, thank you, Carol. Go to the STS homepage and you can click on education. You can just go over to calendar of events. Click on our calendar of events and then go here and click on the 2023 advances in AQO. You can scroll down. Here's your link to register, our dates, and here you can view the agenda. And is my Wi-Fi not working? My Wi-Fi is very slow, so I apologize. And here you will find the information for the entire STS program. And for our General Thoracic Day, we can just walk through the agenda real quick. We have a presentation by Dr. Vetchko on lung clinical and pathological staging, along with some lung case scenarios from one of our data managers. Then we also have post-op events and post-op events case scenarios. We have Ruth will be covering most frequently missed variables. Dr. Tong will be presenting esophageal clinical and pathological staging. We'll have some esophageal case scenarios. Katie and Whitney will be presenting on improving data quality and refining your abstraction skills. Dr. Mitzman will be presenting on how he uses his IQVIA report. And then later in the afternoon, we'll have a presentation from Harris and Ruth on how the analysis is run. Harris is our database. Harris handles all of our analytics in-house for the General Thoracic database. So Harris will be on to answer questions. And there will also be a presentation on star ratings. And to round out the day, we'll have a presentation on how to use your data to drive data quality part 1 and part 2. So we are looking forward to our presentations. In terms of our on-demand content, Dr. Cedar has given an operative techniques video on trachea and esophageal resection. We also have operative technique videos on lung resection and lymph stations. And then Dr. Alex has a presentation on hernia, mediastinal mass, and trachea, most asked questions. And then we have a presentation by our auditor, Dr. Burfing. So we are really looking forward to it. We have a great agenda planned this year. So again, we're looking forward to it. And we are counting down the days. So thanks everyone for for all of those who volunteered to present. It's nice. We do have some new faces presenting this year, so it is nice to have some new data managers. So thank you to our new data managers that are presenting this year. We appreciate you volunteering. Dr. Cedar, are you back just yet? It does not sound like it. All right. So Ruth, let's go ahead and turn things over to you, and we can hop in on some clinical staging.
Yeah, so I thought I'd spend a little bit of time today just talking about clinical staging, particularly for lung cancer. I've gotten several questions of late, and I think there's just some general confusion about what exactly is clinical staging for lung cancer. So generally, patients who have therapeutic resections for lung cancer are clinically staged. Clinical staging is really how physicians determine what stage of cancer the patient has. And I found this helpful sort of information on actually the Longevity Foundation's website, which is linked at the bottom of this slide. And I think when Leanne posts the slides that you'll be able to click on the links is what I'm hoping. But really, lung cancer can be staged once or twice. The first staging is the clinical staging. And we'll go into some more detail, but this includes really imaging and biopsies generally. If you want to click on the next slide. So the imaging tests alone can't tell you that a patient has lung cancer. Things can look very, very suspicious for lung cancer, but you can't prove that something is cancer until you have a sample of that tissue. So this is really guiding the physicians essentially on where they might want to biopsy a patient as they get this information, as well as to what extent the lung cancer might have spread. So patients often will have a spot that's seen on a chest x-ray that then they get a CT scan for, and then potentially a PET scan or a bone scan, depending on where they think they might see metastasis. So if they think there might be bony met, sometimes they'll do a bone scan. Based on the theoretical stage of disease, once they get the CT and the PET, some patients will get a brain MRI. All of the steps to clinical staging are very there's some formula behind it. If you look at the NCCN guidelines for lung cancer, there are guidelines for which patients should and should not get a brain MRI, for example. And then if you want to go to the next slide.
Oh, no, go ahead. I know Dr. Ruth, I'm sorry. Do you mind if we jump back over? I know Dr. Cedar's available. He's in between patients. So I wanted to jump back over really quick because I know he's on a tight timeline.
No problem. We can come back to some more clinical staging in a minute.
All right. Sorry. Thank you, Ruth. Dr. Cedar, everyone, then welcome, Dr. Cedar. Thank you for joining today. As I talked about earlier, we're going to start activating the 2 temporary fields. And Dr. Cedar wanted to come on and introduce these fields that we will be activating and give a little bit of background. So I'll turn things over to Dr. Cedar now. So thanks, Dr. Cedar, for joining us today.
Yeah, absolutely. Leanne, thank you guys. I just wanted to jump on quickly, and I won't take up too much of your time, to introduce and kind of share the idea behind what we are doing here with these 2 new using these 2 temporary fields. So we have 2 temporary fields. One is a yes/no field, and the other one is a text field. We kind of hate text fields because they're hard to analyze and look at, but it's really the best we've got for this particular thing. So what we are trying to understand is, with the increasing use of preoperative immunotherapy and targeted therapy, how often is that occurring, and what agents are being used? So there have been a number of trials in the last couple of years, as many of you guys may know, that have come out that they're showing that for patients with stage 1B and higher, clinical 1B and higher non-small cell lung cancer, giving those patients chemotherapy and immunotherapy beforehand, or sometimes just immunotherapy beforehand, or sometimes targeted molecular therapy beforehand. So things like EGFR inhibitors, these are increasingly being incorporated into the preoperative regimen, whereas 10 years ago patients pretty much, went to surgery for stage 1 or 2. For stage 3, they either got chemoradiation or chemo and then went to surgery. There's just like increasingly number of permutations of immunotherapy, chemotherapy, targeted molecular therapies. And so we're going to try to capture how often is this occurring. And the big picture behind this all is pharma companies are very interested in real world data that a database like the STS database can provide. And so this may be a way to work with pharma and incorporate, some of the resources they have into our data collection efforts by having interesting information that they may be, able to use. So the first one here is going to be sequence 4580. The patient receive induction immunotherapy or targeted agent directed at the lung cancer of interest. Pretty straightforward. In the training manual, we will give a list of, what we consider immunotherapy or targeted therapy. That list may change like on a literally weekly basis. If we're not going to be removing things, we'll be maybe adding new things every week or every month to that list, because there's trials coming out, almost constantly that are showing us new things. And then the second one is, if so, what agent? Might be pembrolizumab or durvalumab or nivolumab are some of the most common ones. So that's about all I really have there. And I thought maybe we could answer any questions if anybody has any specific questions about this.
Thank you, Dr. Cedar. There's one question. Amanda wanted to know if you were referencing the, I don't know how to say it, ADAURA trial.
Yes,
ADURA.
So the ADURA trial was with osimertinib in patients who are EGFR positive. There are data coming out that's suggesting that perhaps preoperative osimertinib in some EGFR patients may be beneficial to their survival. And so yes, that would be one of the targeted molecular agents.
Okay, perfect. Mary wanted to know, Mary, I think you also have your hand raised, and you can ask your question if you wanted to unmute, but Mary, did you want to ask your question directly?
Yes, thank you. Hi, this is Mary. I'm from the Portland, Oregon area. I'm wondering if there are some specific key medications or key words that we should look for so we know what to look for. Thank you.
Of course. Yeah, no, thanks, Mary. I think that, I don't, sometimes they're going to say immunotherapy, or sometimes they're going to say TKI, a tyrosine kinase inhibitor. However, I think that the most reliable thing is going to be actually looking for the drugs, and most of the immunotherapies, for example, end in MAB. So nivolumab, durvalumab, pembrolizumab. That's kind of like a little hint that is an immunotherapy. However, we will provide in the training manual a list of things that, if you see this, then it's definitely immunotherapy or a targeted molecular therapy. And we'll make it as complete as we can. But, it's not going to be your basic chemotherapy agents, your cisplatin and paclitaxel and, the Alimta, all the ones that you typically would see for, chemotherapy. It's going to be these other agents.
Excellent. Thank you, Dr. Cedar. We had one question come in from, I think it's Priya, regarding the induction immunotherapy. Are we looking at patients who are on this therapy at time of surgery or at any time in the past? Any clarification on a time frame?
That's a great question. Yeah, it will be an immunotherapy that's, so one thing about these immunotherapies is, they will, the intent of this is to collect an immunotherapy that is aimed at the lesion of interest. So, for example, if the patient has lymphoma and 3 years ago they got immunotherapy, that's not what we're trying to collect here. So it will be for the lesion of interest, and no one will get immunotherapy or targeted molecular therapies without biopsy proving that tumor. So basically, once you biopsy proven it, if it is immunotherapy or targeted molecular therapy after that, that's what we would consider is what we're looking for.
All right, thank you.
And we will,
we have one more.
Leanne, would you be sure that we can be sure that, or Ruth, make sure that we take note of all these questions, because these are all questions that I think a lot of people will have. And we can put
absolutely.
right in the training manual.
Absolutely. I think we have one more question from, I think that's Heather. Is that Heather?
Yes, hi. I actually just had a request for data from one of our surgeons that's developing a poster presentation. And it was for this very same data, and I had to manually look it up. And I sort of had to do a crash course because I didn't know all the names for the immunotherapy. I had to, Google all these. But what I did was, we have Epic. So I went under the chemo flow sheet, and it would list all of the chemotherapy and immunotherapy that they had. And then I looked them up, and that's how I figured it all out. But I don't know, that may help some of you who have Epic.
Thank you for sharing that, Heather. That's great information. All right. Let's see here.
I think Beth has a question. Will the temporary fields be mandatory?
Right.
So yes, we are considering it mandatory. Just like, a lot of the, it's kind of mandatory. It's not like we're not going to analyze the, the patient. It's not like it'll be excluded from the analysis if it's not filled in. However, we're strongly encouraging everyone, because what we're really trying to do here is establish how many patients are getting this and what agents are being used. So it's highly encouraged, but it's not like the record's going to get rejected if this was not filled in.
Right. And was Melissa, if they don't have access to the medical oncology records, they're at private offices, will there be a not available option?
Yeah. So if it's at an outside hospital and they don't have the records to know, the question is there an unavailable?
Yeah, how would they answer it if they don't know yes or no?
Well, I mean, if they don't know, I think you probably you probably have to answer no. I mean, I don't think
they could leave it blank, right? Just
Yeah.
leave it blank.
Yeah. Yes, I guess, yeah. If you
Yeah.
leave it blank. Yeah.
And we could provide guidance in the training manual. We can talk about it more offline if you'd like, but it's a great question, Melissa. Thank you. And another Melissa had another question, is she wanted to know if these were only questions applicable to lung cancer cases.
Yes, this is not applicable to esophageal cancer.
Okay, perfect. All right.
One tip I would say is don't lose hope that you wouldn't have this information if you don't have access to your medical oncology record. I would say that many surgeons include induction therapies in their pre-op HMPs, and you might be able to find that information there.
Excellent. All right. I'm not seeing any additional questions, Dr. Cedar. If any do come in, we will definitely pass those over to you and then provide additional guidance in the training manual.
All right. Thanks so much, everyone, for all your hard work. Appreciate it.
Thank you, Dr. Cedar. We appreciate you coming on and taking the time and educating everyone on this. So thank you very much.
All right. See you later.
All right. Thanks, Dr. Cedar. All right. So with that, we'll continue on. We'll jump back over to Ruth and continue our clinical staging information.
Before we jump back into that, it looks like there was another suggestion that somebody had, that you could also use your tumor registry for information, which is very true. If your tumor registrars are caught up, they're a great source of information when you're trying to find things like chemotherapy data.
Perfect. Awesome. Thanks, Mary. All right. I think we finished, stopped here on this slide, Ruth.
Yeah, back to clinical staging. Okay, so after when surgeons are clinically staging their patients after imaging, what happens sometimes, not in all instances, is a biopsy. Tissue biopsies are tests in which a small amount of tissue is removed to find out if a person does have lung cancer. So, and if so, what kind of lung cancer? They try to get enough cells actually to do molecular testing to sort of figure out potentially even if targeted therapies like Dr. Cedar was talking about are a good option. So different ways that we can get tissue biopsies: bronchoscopy, EBIS, transthoracic needle biopsies, which are also sometimes written as CT guided biopsies, thoracentesis, which is where they remove fluid from around the lungs. Oftentimes patients with late stage lung cancers have cancer cells sort of floating around in that fluid. So without really removing any tissue from the lung, you can determine that a patient has lung cancer just because of removing some of that fluid. Thoracoscopy, which we see sometimes, patients will go to the OR and have a wedge resection followed by an anatomic lung resection, as a way to determine that a patient truly has lung cancer and that they need a lung resection, an anatomic lung resection for curative therapy. Then also mediastinoscopy are options to determine what clinical stage of cancer that a patient has. If you want to hop to the next slide. So then tying this back to the training manual. So if you look at sequence 1600, it's going to ask you clinical staging done for lung cancer. Again, if your patient has a therapeutic resection, this is almost always going to be coded as yes, because surgeons have to have an idea of what stage their patient's lung cancer is before operating. Doing a therapeutic lung resection on a patient with stage 4 lung cancer doesn't make sense. And so they won't want to do that. So they generally clinically stage their patients. Oftentimes, they document the clinical stage in their pre-op H&P. If you read the clinical stage, and sometimes it's designated with a small c in front of the T, N, and M. If you disagree with how your surgeon has clinically staged the patient, I would recommend discussing it with the surgeon. There's a lot of nuance sometimes in clinical staging. Instead of just reassigning a different clinical stage, I think that's going to cause issues at the time of your audit if you have a different clinical stage than your surgeon has documented in their note, unless you have clear guidance from your surgeon that, you know, they agreed and the clinical stage that you've abstracted is correct. One of the few times that I've seen therapeutic resections without any staging occur is when sometimes patients have open heart surgery. Surgeons will wedge out just like a little bit of lung while they're in there thinking, you know, oh, whatever, I see something while I'm in here, and it turns out to be a teeny tiny focal area of lung cancer. And in those instances, it really is a therapeutic wedge resection, and you will say, no, there was no clinical staging done, because it was sort of like a blooper that the patient ended up with that therapeutic resection. I think that's one of the few instances where I've seen sequence 1600 answered as a no and have that be correct abstraction. If you want to go to the next slide. So clinical staging methods are listed out in sequence 1620. This is not intended to be a comprehensive list of all of the ways that a patient can be clinically staged. Of note, almost all of the biopsies of the mass itself are not accounted for, which was a big switch from 241 to 521. So CT guided biopsy of the lesion, a bronchoscopic biopsy of the lesion itself, or some sites are now even doing what they're using, like an EBIS scope to do a biopsy only of the lesion without evaluation of the mediastinum. And there's nowhere to record any of those procedures. Most patients have a CT scan at minimum before they go to the OR, which would be captured in sequence 1620. If you want to go to the next slide, Leanne. Lung cancer T stage. So the questions that I'm getting are, you know, why is there not a clinical TX or T0 option available to select an 1810? And the reason for that is that if clinical staging truly was not performed, so you would have a TX, you would have coded no to 1600 in the first place, and you wouldn't be answering sequence 1810. clinically, TX and T0 aren't indicative of cancer, so we wouldn't be capturing those as lung cancer cases, is the other caveat. So truly your clinical T stage, it's not going to be written down for you in any sort of an imaging report. You're not going to find it at the bottom of your CT scan or your PET. It's really coming from a clinician putting together all of the pieces, biopsies, imaging, patient's clinical history, and coming up with that clinical stage. Again, if they don't indicate it for you in their notes, you can use this chart, which is linked in the training manual. I've put a screenshot of a portion of this chart over on the left-hand side of this slide for you. But click that link and you can go through this and you can come up with a clinical stage for your patient. But hopefully your surgeons are putting this in the notes for you. And I think that's the end of my slides. If there are any questions about that, feel free to drop them in the Q&A.
Yep, thanks, Ruth. Yeah, we do have some questions. Really quickly, just before we move on, our September 27th user group call is canceled. We'll be slap dab in the middle of AQO, so we will be canceling the user group call, but then we'll pick up again with our monthly webinar on October the 11th. So let's jump over to our questions. Our first one from Melissa. Can you confirm if the esophageal clinical staging values for 2220, T1A, T1B, T1 as specified, new values for version 5.2 are included in the analysis and not excluded? And I think this is actually going to be information that will be covered in the AQ presentation in a couple of weeks from Ruth and Harris. And that should be in the analysis overview. I think, I don't want to answer off the top of my head. Ruth, do you happen to know off the top of your head for that one?
I know we were having some conversation about this because I think there was an issue between the database versions that we were working through. So I don't know if Carol has a final on that, but if not, we should probably just leave it for AQO.
Yeah. And Melissa, yeah, we were talking internally with Harris as well. So we will continue to look into that. Like I said, I don't want to answer it off the fly and not provide correct, accurate information. So I will follow up if we do not catch up before AQO. Real quick, I just wanted to read the announcement from Nancy. I don't think she's on any longer. She wasn't able to stay on the entire call, but Nancy Rodriguez, she just wanted to say a quick farewell to everyone. She is retiring as of October the 4th, and she's been with the GTSD registry for 13 years. She's been a member of the core group, and she's been invaluable, and we appreciate all the volunteer and everything Nancy has done for the core group and the GTSD over these 13 years. So she has included her personal email. She says it's been a privilege and to get to know each and every one of you and to work with you all. So she has included her personal email. So if you would like to stay in touch with Nancy, her email is there, and I do have it as well. So if you don't capture it, I do have that. I can get you in touch with Nancy if you'd like. So just wanted to share that. Our next question regarding the temp fields, are we continuing to use 4590 and 4600 for COVID reporting? And yes, we are continuing to collect that COVID data. So we will still continue to use those two temporary fields as well. Next question from Laura. Ruth, when we are abstracting a case for a hiatal hernia or thymectomy, will we leave 4580 blank or mark no?
I think this is something we need to put into the training manual, but my suggestion would be to leave this blank is my current understanding. So those are the temporary fields that only apply to the lung cancer patient. So I would leave them blank.
Okay, thank you. Next question from Laura. If all lung cancer testing is done 4 months prior to treatment or surgery, do we check yes to 1600 and leave the testing areas blank, or just not check 1600 at all?
You would answer yes, 1600 if clinical staging was done.
All right, perfect.
And then answer 16, I think it's sequence 1620 is the sequence with the time frame. Let me tab through the training manual quickly. Yeah, 1620 is the one with the 4-month time frame. So if you have nothing, you would select in 1620, you would leave all of those blank.
All right, perfect. And yes, Heather, I agree with, we will definitely miss Nancy. But wish her the best in her retirement, and I am very jealous of retirement. I think I have about 15 years left to go. Not that I'm counting down. Do we know a time frame for collecting this new data? We'll begin collecting it October 1, but I don't have any additional information. We'll get more information from Dr. Cedar and others, but is that, I don't know if that's what you mean in regards to time frame.
And it would be for cases performed October 1 or later, correct?
Right. Yes, correct. October 1 forward.
That
Yes,
was it.
thank you.
And then Leanne, you answered one of the other questions, which is, are we going to continue collecting the temporary fields for COVID? And that is a yes.
And contact information's here if anyone needs to reach out. Let's see here. We got another question. Can we submit an inquiry for someone at AQO to go over properly counting lymph nodes when an EBUS is performed? I think I understand, but I'm not sure.
Yeah, of course.
It smells better.
Oh, I think there's some background noise. There we go. Got it. So yes, we can get that added. Some education on that. Happy to do that. When is the deadline for registering for AQO? Let's see. I don't think Emily is on. I don't know the deadline for AQO. I would register sooner rather than later. I think the virtual platform may go live sometime within the next week or so. I'm not sure. Don't quote me on that. But again, more information will be coming out. If you contact, let's see here. Hold on. Let me pull this over. Let me pull over the program. If you use this link here, if you go scroll down, if you use this link here, meetings and conventions department, if you click here and just submit that question, someone from the meetings team will let you know what the absolute deadline is for registering for AQO. I'm not exactly sure, Melissa, so I don't want to tell you wrong, but I would just use this link here and just submit that question and they'll get right back to you. Did you say you'll be contacting third-party vendors to be sure the new sequences need to be added? So yes, we will be contacting the vendors. So the communication will go out from STS, and that communication will be sent to all the participants as well as the vendors. So yes, that communication will be going to participants and vendors. All right. Any other questions? Let's see here. Again, next webinar, the 27th, that's was canceled due to AQO, and then we'll pick up again on October the 11th. All right, I'm not seeing any additional questions come in. So with that, thank you everyone for joining today. I appreciate you guys. I'll give you back about 20 minutes of your afternoon. So thank you all for joining. We look forward to seeing you all at AQO virtually in a couple of weeks. It's going to be a great day. We have a great program lined up. So we are looking forward to it. If you have any questions in the meantime, please feel free to just shoot me an email or just reach out to us directly. Happy to help in any way. So thanks everyone. Thank you, Mary. Hope you guys have a great rest of your afternoon.